Today's session is going to be about coronary arterial anatomy. The focus of this talk is mainly on the terminology that is used, why a particular coronary artery is named so, its nomenclature, its significance, and some common coronary arterial anomalies that we come across and how we describe them. So coming to the nomenclature, the coronary arteries are based on the intermediate and the distal vascular territory of the artery. So we are not taking into consideration from where the coronary artery is originating, but the focus is on how it courses through and where it terminates, and based on that the arteries are named. So the left anterior descending artery is a subepicardial artery which courses through the anterior interventricular groove and provides septal branches. So regardless of its origin from the aorta, an LAD is when it courses the interventricular groove anteriorly. Similarly, the circumflex artery is said to be the one which courses through the left atrioventricular sulcus and the one which provides at least one obtuse marginal branch. And the right coronary artery is that which runs in the right atrioventricular sulcus and gives off at least one acute marginal branch. So what does the coronary dominance refer to? Artery which gives off the posterior descending artery is considered as the dominant coronary artery. So in approximately 85% of the population, the right coronary artery is said to be dominant, whereas in about 7 to 8%, the LCX gives rise to a posterior descending artery which becomes the left dominant system. In the rest of the patients, there can be a co-dominant system or a balanced circulation where a small PDA can be seen arising from the right coronary artery with posterolateral branches from the LCX artery, or there can be PDAs originating both from the RCA and the LCX. Coming to the right coronary artery, the right coronary artery is the artery which supplies the morphologic right ventricle. It arises from the right sinus of alfalfa and travels in the right AV groove towards the acute margin of the heart. Now we need to be aware that while describing the coronary arterial anatomy, the right ventricle is said to have an acute margin, whereas the left ventricle has a more smoother and rounded obtuse margin. So when the right coronary artery reaches the acute margin, it turns to continue between the right atrium and right ventricle at the base until it reaches the junction with the atrial and ventricular septa. Now coming to the RCA segment. Proximal RCA is that which arises from the coronary ostium up to the level of the acute marginal branch. The segment from the acute marginal branch till the acute margin of the heart, as we already showed from the earlier image, is the mid segment, and everything distally is the distal segment. Now coming to the branches of the right coronary artery, in approximately 50 to 60% of the population, we have the conus branch, which is the first branch of the RCA to supply the right ventricular outflow tract. It is also an important source of collateral supply to the LAD through the so-called circle of Usens, which in selective cases can be used to collateralize severe cases of left main coronary artery or proximal LAD disease. Now coming to the acute marginal branch, this is the second branch and supplies the RV3 wall. Typically, halfway point between the RCA and the ostium, the acute margin of the right heart border is the dividing point between the proximal and mid RCA segments. So this is often represented by a large acute marginal branch. There can be other branches like the SA nodal branch or the AV nodal branch, which may be seen in some parts of the population, but these are not really constant branches. Coming to posterior descending artery, like we already said, this is the artery that defines the dominance of the coronary arterial system. It runs in the posterior interventricular groove between the right and left ventricles and supplies the inferior wall and inferior 1/3 of the interventricular septum. It can arise from the distal RCA in approximately 70% of the population, or distal LCX in 10%, or can have a codominant circulation in approximately 20%. So this is an image representing the posterior descending artery in its interventricular course along the inferior margin of the heart. Coming to the left main coronary artery, it typically arises from the left sinus of Valsalva. It typically does not have significant branches of its own that quickly bifurcates into LAD and the circumflex coronary arteries. Coming to LAD, this is the artery that arises from the bifurcation of the LCA and travels in the epicardial fat along the anterior interventricular groove and typically has a distal descending course. It gives off diagonal branches to the anterior left ventricular wall and septal perforator branches which supply the anterior two-thirds of the basal interventricular septum and the entire septum at the mid and apical levels. Now the segments of the LAD. From the origin of the left anterior descending artery up to the level of the first septal perforator is defined as the proximal segment of the LAD. The segment from this origin of the first septal perforator up to midway between the part where the LAD forms the angle, that is the acute margin or obtuse margin of the LAD or the level of the septal perforator, or for practical purposes while reporting on the CTs, we use the origin of D2 as the level for the mid LAD, and everything distal to this is taken as the distal LAD. Circumflex artery. This arises from the left common coronary artery and travels to the left atrioventricular groove supplying the lateral wall. Unlike RC and LAD, LCS has only two segments. It can give posterolateral branch or an obtuse marginal branch to supply the portion of the inferior wall. It also supplies branches to the AV node. The proximal LCS segment is and includes up to the level of the obtuse marginal branch right from the origin, and everything distally is called the distal segment. Now there's emergence of a new coronary artery segmentation model where each arterial segment is annotated by numbers. For example, the right coronary artery is again further divided into the proximal, mid and distal segments are labeled as R1, 2, 3, and then the PDA and posterolateral branches are named as R4 and R5. This is not yet a very popular model as of now. The conventional way of segmenting them is based on proximal, mid and distal segments of the coronary arteries as we described until now. So this is the newly proposed system which is yet to take effect. Now there can be supernumerary coronary ostia, wherein in addition to the typical RC and LCA origins from the aorta, some patients can have smaller branches which arise directly from the aorta. The more common variants amongst these are there are separate origins of the LAD and LCA from the left coronary artery without a common left main coronary artery, or a separate origin of the conus branch directly from the aorta rather than from the proximal artery. And clinically, these do not have any significant implications in most people. Another common terminology that we come across is the concept of myocardial bridging. So normally the coronary arteries travel in the epicardial fat along the surface of the heart. But in some individuals, the coronary artery can dive from the epicardial fat into the myocardial for variable lengths. So this configuration leaves a segment of the bridging myocardium. Like we see in this diagram, the mid LAD is seen diving into the myocardium of the left ventricle for a short segment and then emerging again to traverse in its subepicardial fat course. So why is it important to note and mention this particular anatomic variant? So the bridge coronary segment is frequently spared of the atherosclerotic disease. And there are recent articles which have shown that bridging on CT is nearly a third of the patients who are at low risk of ischemic heart disease. So since it is a rather benign variant, the term tunneling is to be used rather than myocardial bridging, and it signifies its benign prognosis in most cases. The clinical significance of it should be interpreted only in conjunction with the remaining scanning results and the clinical situation. Atypical angina is the typical presentation in most of these patients. Myocardial bridging may rarely cause limitation of flow, especially if the segment is too long or too deep and may be associated with coexistent stenosis. or maybe supplying a collateralized territory. Now moving on to coronary artery anomalies. These are fairly common, occurring up to 0.3 to 1.3% of the patients at angiography and 0.3 to 0.5% at autopsy. Again, there is no definite definition on what accounts for normal and anomalous variants, because the anatomy itself can be variant, and hence poses a dilemma in the nomenclature of these anomalies. Anomalies can be mainly differentiated as anomalies of the origin, anomalies of course, and anomalies of termination. So what is the most commonly encountered coronary artery anomaly? It is ectopic coronary origin from the contralateral coronary sinus. Why is it important to diagnose it? Because some of these forms can be associated with angina and increased risk of sudden cardiac death. So approximately 26% of these patients have some sort of aortic root abnormality, most commonly the bicuspid aortic valve. In general, the origin of the ectopic coronary artery is not problematic, but the course of the abnormal coronary artery which it takes can have significant consequences. So conceptually, such an anomalous origin and course can have 4 different potential paths. One is pre-pulmonic, where it courses anterior to the right ventricular outflow tract, retro-aortic behind the aortic root, septal through the proximal interventricular septal, analogous to a superior septal perforator, or an interarterial course between the aorta and pulmonary arteries. The first 2 of these are considered benign without any significant clinical implications, whereas an interarterial course of an anomalous coronary artery between the aorta and pulmonary artery carries an increased risk of sudden cardiac death. The exact reasons are not very clear, but the most frequently cited hypothesis is that there can be angulation of the anomalous vessel, which results in a valve-like ostial ridge, or interarterial coronaries can have an intramural course through the wall of the aorta. So this can get compressed during the aortic pulsation and cause sudden death. It's typically described in young athletes. So here's a patient with images in systole and diastole, which is showing that the artery can get compressed during systole between the aorta and pulmonary artery and can be a cause of sudden cardiac death. Now here is another common radiologic dilemma. When we are reporting non-gated CTs, sometimes there can be a pulsation artifact at the aortic root, which can give rise to an appearance simulating that of an anomalous coronary origin or course between the pulmonary artery and the aorta. This should not be confused as a coronary anomaly, and it is best to refrain from commenting on such anomaly unless we see the distal course of a right coronary artery distally. So on a non-gated CT, we should refrain from calling it an anomalous interarterial course unless we see the course of the RCA distinctly. An anomalous left coronary artery arising from the pulmonary artery goes by a popular eponym of Bland-White-Garland syndrome. It's usually a presentation in infants or children where they succumb to myocardial ischemia due to coronary steal phenomenon. However, if they are compensated with coronary steal phenomenon, then there is extensively collateralized vessels across the heart with patients who can live up to their old age and present with pulmonary hypertension. So here we see that the right coronary artery is seen originating from the aorta, whereas the left coronary artery is seen arising from the pulmonary artery, and there is extensive collateralization and the coronary arteries are markedly dilated. And this is a picture that we get to see only in patients with adult alcapars, and in children it is rarely seen. Such wide collateralization is rarely seen in children. Coming to definition of coronary aneurysm, Coronary artery aneurysms are typically defined as diameter of more than 1.5 times larger than the adjacent segments. These are fairly uncommon lesions occurring in about 1.5% of the cases and in 5% of patients who have undergone angiography. So in patients who have undergone angiography or some kind of cardiac catheterization, they typically tend to be pseudoaneurysms with segments of dilatation that do not include all layers of the vessel wall. Coronary aneurysms are most common in the RCA, followed by the LAD and LCF. Here is an example of a dilated LAD segment, which is to be classified as a coronary artery aneurysm. Coronary artery aneurysms can be caused by multiple diseases. Most common worldwide is the Kawasaki disease. Others including atherosclerosis, Takayasu, Cocaine and genetic syndromes such as Lorenz-Dietz syndrome. Like other aneurysms, its complications include rupture, thrombosis, and distal embolization. Coronary aneurysms are most often incidentally discovered, and their management still remains controversial. Now, what is the most common indication for surgical repair of a coronary artery anomaly? Are coronary fistulas and arteriovenous malformations. These are fairly common and complex coronary AVMs in the medical literature have been described and diagnosed. Collectively, they have been described in as many as 0.5% of the coronary angiograms, and they are the most common indication for surgical repair. Here is one example showing a dilated right coronary artery with fistula formation. Usually, they have a benign clinical course. They're symptomatic because of their left to right shunting, later on developing pulmonary arterial hypertension. Coronary steal phenomenon is well known, which typically leads to ischemia and rarely infarction. In some cases, severe symptoms and striking imaging findings can be present. And imaging is basically used to outline the anatomy and to help plan treatment. What is important is that whenever these conditions are detected, for the diagnosis, the AVMs have to be imaged up to the aortic arch because there can be significant bronchial contributions, and so it is important to plan the surgical intervention, and hence the roadmap needs to include the aortic arch. So that's all about the coronary artery anatomy, its nomenclature, how to describe the coronary segments, and some of the commonest coronary artery anomalies that we come across. If there are any questions, I'll take them.